Yeah, it is
Yeah,
recording now.
it's only started now. Yeah, that's good. That's such an interesting topic and so relevant nowadays.
Right?
There's so much focus on, at least here in India, you know how it is, right? Grade
Yes.
11 and 12, and
Yes.
then getting into medicine or engineering or your IITs and,
Right.
you know, all the headaches, the eye strains, blurred visions.
Yes.
We're getting a lot of spasm cases also,
I
Aparna.
know. I figured. I think over the years, me too. I think I've seen. I think I spoke to Prem Nandini also, and she was saying
Mm,
how they're also seeing
mm.
so many, and it's like so underappreciated. But
Yeah,
I think also many of the pre-myopes before they become myopes have also have
yeah,
this accommodative spasm that comes
correct.
on and then releases off to become myopia. I think so.
Myopia. And then you're not sure whether you want to prescribe
Prescribe
or
or
you don't
not.
want to prescribe to start with because you're not sure whether you're really, completely rid of the spasm.
Correct. Correct.
So
Correct.
so there's so many small little things to sort of look into before we start prescribing glasses.
Correct, I know. And many times I think we also are like so premature, especially
Yeah,
myopes. I think low myopes, you could give them like not prescribe. Like at least the 0.75 is also, if I don't see any complaints, I don't prescribe. I wait. And then I sometimes, because it's like they have such different blur adaptation, you know. So
yeah,
the same 0.75, 1.75 can do just fine and be okay. And the same
correct,
0.75 can have like a super sensitivity to blurs and
correct.
more hyper performing. So I think it's
Yeah,
I don't know, the way the brain and the mind and the vision like all work together is just so fascinating from one
it is.
individual
And
to
it's
another individual,
extremely
how it can change.
complicated, right?
Yeah. And it's not like a prescription that you can say,
No,
okay, this is the standard of care practice, right? Like overall, this is
correct.
the standard of care of practice, but you have to use your mind, you have to use the scenario, you
Every
have to
time.
use the
Yeah,
conditions around it to prescribe, you know. So I think
yeah,
that's what makes it interesting for us and
correct.
challenging and keeps things like moving, you know, and how
Yeah,
to adapt to the
absolutely.
things around you. So anyway, it's like a
So true.
I don't know. I hope I
So,
cover.
so
Like I know Shamla sent questions also, but let's see.
yeah,
It's a busy content, but I'll also break. And anytime Sharanya, if you like, ask questions,
yeah,
remind me, and I'll stop and
yeah.
answer.
Okay, perfect. Shamla, do you want to start?
Yes, ma'am.
I think we're getting enough people in.
A warm welcome to everyone joining us for the Acchutha Inspired Series 16. It's my pleasure to introduce our distinguished guest, Dr. Aparna Raghuram. Dr. Aparna Raghuraman completed a Bachelor of Optometry from LX School and earned a PhD from University of Mysore. She's now currently the Director of Optometry at Boston Children's Hospital and an Assistant Professor at Harvard Medical School. Since 2023, she has also been serving as Vice Chairperson of Pediatric Eye Disease Investigator Group, commonly known as PEDIC Study, contributing greatly to the pediatric vision research. We are honored to have you with us, ma'am, to share your insights and experience on the topic from exam room to classroom, applying eye exam findings to academic performance and learning. Please join me in giving a warm virtual welcome to Dr. Aparna. Over to you, ma'am.
Okay, thank you all. I think it's a good evening for you guys there and good morning for me here. But yeah, thank you, Shamla and Gopi and Sharanya for inviting me to do this talk. And I'm a pediatric optometrist. I've been at Boston Children's for the last like 25 years. And but my inspiring training and all came from Sharanya actually. She was like my peer, my mentor when I was in LE school and Shankar Netralia. So a lot of fond memories from there. So I'm always happy when she asks me to do anything, I'll be always ready to do it. So that being said, let's give a little idea. Like, so I'm going to talk a little bit about like how going from like the lecture is aligned in such a way that I'm going to talk a little bit about just general basics on how to do a good binocular vision exam, and from there it'll go on into looking at what all we should think about in terms of just small refractive error to binocular vision issues to dyslexia, like what should we be thinking about, and I'll end a little bit based on time that we have, hopefully a little bit on concussion as well and how to think about it. So the main objectives is, again, we're going to talk about what is visual function evaluation, what does it entail. We'll talk a little bit about going from refractive error to amblyopia to strabismus, what we should think about in terms of learning outcomes, and then we'll try to understand how we have to, as a vision care provider, um, uh, be able to advise our families and patients that we see for these deficits that we might notice. Visual function is kind of like a global terminology that we all use right now to kind of describe many aspects of vision, under which you have like low vision. Low vision is the one that we all know, like decreased vision and decreased visual acuity. Functional vision are those patients like with CVI, with brain-based injury, where you're trying to understand what functional vision is. And binocular vision are patients who have like normal vision, but still you have to understand how their eyes are teaming and working together beyond refractive error correction. So these are kind of all the umbrella umbrella term that visual function is typically used, but I'm almost going to talk more only about the visual function from a binocular vision aspect. So when we tend to do a comprehensive eye exam, at least here or most practices, patients come in because of failed vision screenings or things at screening at school or screening at the pediatrician's office is when they come to our chairs. And many a time you don't focus on much of the eye exam, only involves like identifying if they can see well or not and giving them glasses. Sometimes even near vision is not always tested. And there are a couple of like small tests that we tend to do, we don't tend to do, and we don't always also probe and ask the right questions for the patients, right? So that's kind of what the comprehensive eye exam involves. But you go probing more, you start looking at visual function. So this is where I'm going to spend the time, and we are all need to be well versed at doing these tests. They don't take much time, but it is matter of doing the test consistently in a proper way and making sure you are doing it the same way every time, adapting it, of course, to the patient's needs, but you're actually doing it properly and understanding what's the norms, what values you're seeing, so that you know how you're gauging this. And most of the time, these are underestimated, but you just need to make sure you're doing it properly, so that nobody's doubting on what kind of at least exam techniques you're using, because many of them still have a subjective nature to it. So you need to be very careful at doing it. So let's talk about, typically when I talk about visual function eye exam, I do the distance vision, near vision, and then I start looking at like cover testing or whatever test, and then comes my binocular vision exam, which is the visual function exam. The first thing we are going to look into is the vergence. The vergence system is how the eyes are working together. We can talk about it in terms of amplitude, in terms of ranges, and in terms of facility. So when you talk about the amplitude, you're talking about the near point of convergence, very useful tool, but we need to make sure we are doing it properly with the right target. So it's good to use this simple like accommodative target. If you use more and more like a dissociative target like a light, then it is for a different reason you would be doing so. For example, if it's an intermittent exotrope that you have on your chair, you might first use an accommodative target to stimulate, and then when you go dissociative target, you can see how the eye is kind of freezing out when you do a more dissociative target. So what target you use is very important, and what you're looking for and what instructions you give is also very important. So this is like your near point of convergence is the maximum amplitude of convergence. So think about it as voluntary convergence, because there's so many mechanistic action that helps to drive that convergence. So we all make sure that we use a rule. Here I'll also stress, I think I have a video, and after the video I'll explain a little bit about where you're doing, or maybe right now. So you also need to make sure that you're measuring from a right place and the right manner. So it is important to use like an accommodative target, and I was trained like in India to do it from the lateral canthus, which is absolutely fine because that's the center of rotation of the eye, or you can use from the middle of the forehead. US, most people use from the middle of the forehead because Scheinman and Vick and all their data points are all from the middle of the forehead. There is a difference between middle of the forehead to the lateral canthus by about a centimeter or centimeter and two. So your normative data points that you compare with can be different based on what you're doing. So make sure you are consistently following where you're where you're keeping the measurement from. Then when you're looking, because I want to spend a little bit of time because this is a very easy test which we can all do, but doing it properly is important. When you bring an accommodative target towards the patient's eye, the instruction you give the patient is, please tell me when the target splits into two, that you see two, and then when it comes back to one, as I pull it back, is what you are going to notice. But you also tell the patient that it might get blurry sometimes. Don't worry, push through the blur and let me know when it actually gets two, because most subjects will always respond immediately to blur. When they see the blur, they'll say, oh yeah, it's double. But no, if you double check and ask them, they're actually responding to the blur, you push it forward. What can you do as an observer? As an observer, you can also look at the eye and see exactly when fusion is broken, right? That is exactly the point when they should say double, and you are noticing it too. But in some conditions, like for example, if a patient has intermittent exotropia or very receded convergence, sometimes the eye drifts out. What happens? The eye brain can suppress, right? At that point, they will never see the target doubling, but you see the eye drifting out. So that is the point of break. Don't keep pushing further. So that's when people record normal near point of convergence, even in cases where there is like a huge intermittent exotropia and suppression going, because you are just only looking at one eye and the other eye is actually drifted out, and the patient is not reporting double because the eye is suppressing. So these are small important things and cues that you should learn and remember to do it properly. Then comes the fusional vergence. We all have prisms bars in the offices. So you just take the prism bar and you can check how much maximum you can converge and how much maximum you can diverge. Then we have the vergence facility, which probably not all of us have these tools, but it is a wedge that has a 12 prism diopter, 3 prism diopter prism wedge. And so basically you are trying to mimic how well you can simulate a dynamic virtual world, right? Most of the time things are static when you check vision, but these are things that are looking into more dynamically how the visual system is processing. So when you do the vergence facility test, you're looking at how well the eyes can shift from a convergence demand to a divergence demand. And this also, it's very important as an observer to look at the patient's eyes carefully, because many of them are not interested or not even doing the task when they're children sometimes. So you need to alert their attention to make sure they understand what to do and look at their eyes when they are doing this test, so you can see the convergence and the divergence demand. So this is a little bit about how to check gross convergence amplitude. You're bringing a target towards the patient's eye. You place the rod at the middle of the forehead between the two eyes there, right there to measure. And then you bring the target in front of the eyes and ask the patient to report. So we have like this a vertical line of letters that are 20, 30 size letters, but the letter E on the cube is very good to use. Anything that is relatively reasonable size between 2050 to 2430, which is like equivalent to 612 to 69, in your case is a good target to use. So basically, this is a small video and it's just to show what to observe. This child has intermittent exotropia, so you can kind of see. I am using a pen target because it was easier to do, but ideally an accommodative target would be better. So let me just play the video.
No.
The 10-minute becomes one back again.
No.
So this is a video just to show how it is. In this case, it's very apparent that the left eye drifted out. That is your point of fusion. And the child reported double exactly at the same time. But you have also observed it. And then you pull it back. You can see it jitter a little bit and then come back to single. That's your stable recovery point. So this is important to just to show that point of how objective observation of the patient is very crucial. And it's important to use an accommodative target when you can. When you use a pen tip is also fine when you have nothing. But if you use a light or a point source or a pen light source, it is more dissociated. So the values will be further more receded in those cases. So this is another way where you're actually observing when the eye is drifting out, when it breaks fusion for you to know. It's as simple and probably very redundant information to all of you guys, but it is something that is so easily missed. And because patients also respond to blur and not to double. So make sure that has happening. So then you want to look at the convergence and divergence ranges. So first you always do the divergence because you want to not stimulate accommodation too much. And then you do the convergence. Also, again, it is important. This is like as you're looking for divergence, you will see the eye kind of go out. And then when it breaks fusion, they will see that image is shifting because they're seeing double and they're moving their eyes back and forth. Same thing for convergence. You will see the eye converge. So also make sure that you're importantly observing the patient when you're doing the test. You can also do vertical ranges for vertical forias. Then comes the vergence facility. This is again a quick slide just to show. So converge, diverge, converge, diverge. So that is what you're basically using a target and you're asking the patient to report when the letters in the target are clear and single. It is important to say clear and single. It can be single sometimes, but not clear. So you need to give them time to make sure it becomes clear and then switch to the other side. Sometimes it is double, it is clear, but it's double. Then you have to make it single before this happens. These are small things that you have to keep a note when you are doing the test for vergence facility. You typically do it for a minute and you calculate how many cycles per minute they are able to clear. But this is not always a common test available to all of us. I'm not sure whether it's there in India, but this is something you can even take a loose prism wedge of 15 and 3 and you can go or 12 and 3 and go back and forth between the two demands as well. So again, this is what you're looking for in the convergence facility. Then comes the accommodative system. Very similar again. In the accommodative system, again, you're going to check how much maximum they can accommodate, what is the ability to modulate their accommodation, and when you ask for a particular demand, how accurate is their accommodation. So with the amplitude, you have the amplitude of accommodation that you can measure. Again, it's important to use an accommodative target. Be consistent with your size. If a patient has 6x6 vision, you can want to use at least a 6/9 or a 6/12 target when you're doing the accommodative testing. Then you have the facility for which we use the plus or minus two flippers. We can use an accommodative rock card in this case, or you can ask the patient just to say when the target is clear or not. Somebody is not muted. If they can mute, that'll be great. And then you can look at the accommodative response. And for the accommodative response, which is also called as dynamic retinoscopy, you might all know it as an MEM, depending on how you're being taught. And we'll go over a little bit about it. We use these cards and you check the accommodative response. For the amplitude of accommodation, use an accommodative target. You bring the target towards the patient's eyes and ask them to report when the target gets blurry. And first, they will get blurry. You wait. You ask the patient to say, is it clearing up? Many a time, there is a last push of accommodation that comes into play, and they will be able to clear the target. Give them time, then move it forward for a sustained blur. Again, you measure it from the middle of your upper on top of your eyebrow, or if you're doing it from the lateral canthus, just make sure you're consistently doing it the same way. But the normative data are typically mostly recorded from the middle of the forehead if you're using Scheinman and Wick kind of databases. So then you have the facility test. Facility test is what it's doing. It is actually checking how well your eyes are relaxing and focusing. Plus lenses relaxes the eye. Minus lenses stimulate accommodative system. So minus lenses minifies the image. Plus lenses relaxes makes the image size larger. So when you're doing it, you're doing a plus or minus 2 flipper. Basically, this is what is happening. Minus lens makes the things look minimal and minus, but in this way, you are stimulating the accommodative system. You are trying to understand how the patient is relaxing their eyes when they're looking far away and when they're looking up close and stimulating their accommodation. What is their functionality doing? And this is what you are measuring. And you are using a +2 -2 lens, which is well within the power of the accommodative amplitude a child to an adolescent to a middle under 25 years could do. That's why we use a +or -2 lens. When you go above 30, you go down on the flipper to a ± 150, and beyond 40, we know we lose our accommodative system, so ± 1, and then we slowly lose that too as well. Then we can't do much of with the accommodative facility test at that point. So then you have the dynamic retinoscopy or accommodative accuracy, monocular estimation method, whatever you might call it. This is an accommodative test where you are using those cards and you can put it on the Welch-Allyn retinoscope because it has a small magnet on it. You can put it on it. You can put a sticker, anything that alerts the attention, alerts the patient's idea to look at the target and focus on the target. So when you do this test, for example, you are scoping from 2.5 centimeters, from 40 centimeters. 40 centimeter, the accommodative demand is 2.5 diopters. So what are you doing here? You are trying to see how well the system is accommodating to that distance. Evolutionarily, we all know our system wants to do just the enough job to focus, right? It doesn't want to exert too much more than what it needs to. So we always get, instead of 2.5 diopters, the system accommodates only 2 because it uses depth of focus for the remaining system. So the remaining lag that you see, half a diopter, is the slow with, like not a slow, like a bright, but a width reflex that you see. That is what you neutralize with the plus lenses to check what the lag of accommodation is or what the lead of accommodation is or how accurately the patient is accommodating. But this test is affected by corrected status. If they have uncorrected hyperopia, uncorrected myopia, uncorrected astigmatism, you can actually use the dynamic retinoscopy will pick up on all these cues. So if you want to interpret it the right way, it is important for the child's refractive error to be corrected or an adolescent's refractive error to be corrected. If it's not corrected, you can still, for example, a 4 diopter uncorrected hyperop is there. We are scoping for distance uncorrected, right? Or looking at the target and looking at distance. Some 4 diopter hyperop will beautifully accommodate to the target and just be fine. These are patients where you don't have to prescribe for your glasses if they are on the borderline and you can wait and see. But if they have a lag of accommodation for the 4 diopter, you're almost getting 4 diopters when you're doing dynamic retinoscopy. Clearly, the patient is not accommodating to the target properly because you have to first saturate for their refractive error and then compensate for it. So this is where this is my favorite tool. Your retinoscope is your best tool. You can do so much with it if you know exactly how to use it properly. You can pick up your uncorrected, uncooperative child. You just quickly scope 90 and 180. You can figure out if they have astigmatism. So it is a very beautiful tool to use no matter where they are looking, how they are looking in a way to get a gauge for what it is. But it is a great measure for accommodative accuracy. So then comes visual tracking. This is where we can do free space tracking or you use tests that can help surrogately influence tracking what you have for reading and see how the patients do. So DM is like this test. We'll go and then you can also use the eye trackers these days. We all don't always have these sophisticated equipments in our offices. First of all, it's time consuming and it's expensive also. So the first thing before that, let me just do free space testing. You can do pursuits. You can do a target moving back and forth. You can have them look back and forth between the two eyes. You would have all probably heard about the Ensuko technique, and you're looking for if they're able to keep with their eyes or they're moving their head, and then you document all that in free space. If you're more familiar with this literature a little bit, recently with the worms, they use it more consistently. Like for tracking, you do 5 cycles, and then you wait, and then you see how the eye settles in. Is there a jitter? Are they able to stabilize? For saccades, you go at least about for a minute back and forth. You can calculate like number of cycles they are able to go back and forth. You can also do vertical. You can also do little vestibular by having them look straight at the target and moving their head back and forth or up and down. So you can do various things by just using your finger to do all these testing, or a target or a letter target to fixate. The developmental eye movement test is my favorite because it is a test that has vertically aligned numbers that helps for assess processing speed. And the same thing is numbers are aligned horizontally like you would make a saccade when you're reading. It's simulating a saccade. It's not a true. If you put an eye tracker and do it, it might not be exactly the true, but it is the quickest, easiest method that you can get to test for your tracking. So you can actually have these numbers horizontally aligned and you can check for how the eyes are tracking, and you have normative data that is established for different people have done for like the Spanish speaking population, even though the numbers there are different populations done, but you have values that you can compare it against with. Typically it takes around like 12 years of age for the time to be exactly the same ratio between the time taken to complete the horizontal to the vertical, but we have normative databases that you can use. You might have also heard the King-Devick system, KD system that you can use. It just only has the horizontal tracking spaced apart, not the vertical. So you don't have an estimate about the processing speed, which can be a very good tool to use when patients have learning difficulties and so on. And then you can use the eye tracker, which we talked about. When you do all of these testing, it is also important to understand what is normal, what is abnormal, what are the values that you should use for a child between like 6 to 10 and then 10 to 15, 15 to 20, the adolescent and the older cohort. So you kind of get a gauge. But sometimes with high-performing children, sometimes you might need to push these limits to a little bit more as well. So it's good to have an understanding of what normative value is. So let's go a little bit into the visual function, like what kind of narrative, what kind of evidence that I can give you in terms of why it is important to correct hyperopia, etc. So first we'll start with refractive error. When we talk about refractive error, first let's talk about like evidence-based studies that can help us guide us towards this direction. So here we have simulated hyperopic refractive error. So these studies were done by Joanne Wood and a couple of group in Australia, where they looked at, okay, what happens if you simulate hyperopia. So it's a small group of prospective study. They took patients and they simulated hyperopia of 2.5 diopters. So before they did that, they looked at their baseline measures, and then 20 minutes they were made to do some sustained work, and then they were measured again. And they looked at their reading ability before, how did they do on this WISC test and the DEM test to see prior and after what kind of impact uncorrected hyperopia had. And they found that the dashed line is like with the optimal correction, like baseline. Even that, after 20 minutes, there is a fall. But when you had the simulated hyperopia, there was a significant drop in function after their reading rate was much lower. Their coding symbols got much more harder. The developmental eye movement test, the horizontal time, particularly, they took longer time to do the task. And they found about 5 to 24% reduction can happen in these academic measures with simulated uncorrected hyperopia, right? So then they went on to show what happens if you have astigmatism. So then they simulated astigmatism, again, a small group sample, and then they looked at 1.5 diopters of bilateral astigmatism simulated both with the rule and against the rule. And they did the same thing before and after, 20 minutes of sustained near work to see how their measures are affected. And they found that the reading ability, as well as all of them, about 5 to 12% reduction did happen in these cases when they were simulated astigmatism across the board, including the DM horizontal time. But more than hyperopia had more of an impact. Astigmatism had a minor impact, but it did affect it. So then we have these studies that were done in the United States by this group of people from Arizona, where Arizona had like a American tribe, Native American tribe that had very high incidence of astigmatism. So they were able to do a study here, taking these patients who had uncorrected astigmatism and assessing how their oral reading fluency was. And they were able to recruit patients who had low astigmatism, moderate astigmatism, and very high astigmatism in this range. If they had to be less than 1 diopter, 1 to 3 diopters, and greater than 3 diopters. And they had patients who were children who were between the 3rd and the 8th grade. And they found that their oral readings fluency with the low astigmatism, not bad, but when they had moderate to high astigmatism, it dropped significantly. And when you correct them, it does get better, but it takes time for it to kind of come back into the normal curve. So it is those moderate and high astigmatism, particularly the high astigmatism, when they have greater than like 2.5 to 3 diopters more, you have to be particularly sensitive about correcting them appropriately. And it can affect both near and distance vision. That's why it's important to correct astigmatism. A small caveat here for you all. When you think about with the rule, against the rule, and oblique, think about it properly. With the rule, astigmatism is a little bit more compensatable by the system. The way the English letters are aligned as well, the way it blurs. With the rule, astigmatism, you can guess the letters better, whereas against the rule and oblique, it's a little bit more harder. That's why for a smaller magnitude of against the rule and oblique astigmatism, it is important to correct. Like if it's 0.75 to 1 diopter, the blur might be different. The way they are adapting to it may be different. The cognitive demand for near reading can be different. So it is important to correct these uncorrected astigmatism adequately. The last graph here shows with respect to grade, because as grade level increases, the more cognitive demand you have for near, the smaller the font size that you're going to be seeing on these reading booklets. So it is the 6th and 7th graders, especially as you go into 5th, 6th, 7th graders, where the uncorrected astigmatism affected a lot more of their near performance. So this is all giving you cues as to why you need to correct those hyperopes or why you need to correct those uncorrected astigmates that you see. So another set of studies came from the vision in preschooler study. This is like a huge network of optometrists, ophthalmologists, orthoptists, and like a big group of clinicians coming together and trying to understand how to screen for hyperopia. And there were a lot more studies that are done on this. I won't go into it, but I'm going to talk about how they found uncorrected refractive error can affect literacy. So they took 4 to 5-year-old children who were between hyperopes between 3 to 6 diopters, who are the patients who sometimes go uncorrected because you don't know when to prescribe and you want to wait. We have different prescribing philosophies. So we all have different nuances on how to treat these patients. So they took this group and they had an emmetropic group. So a good large sample size over across United States. They had many sites and they were able to look at the comparison between these two groups. And they found, and what did they measure? They looked at something called an early literacy called the TOEFL score. TOEFL helps you aware like print knowledge, your phonological awareness, like how are you looking at those letters, and also looking at definitional vocabulary. When they did all this, they found that the uncorrected hyperopes especially were affected by the print knowledge. The print knowledge is what affected their, when they were higher hyperope, that they performed more poorly, especially when they were greater than 4 diopters or more. Their ability to have this print knowledge awareness was affected, not the definitional vocabulary or the phonological awareness. So they went on to show that if you have uncorrected hyperopia greater than 4 diopters, or if you have between 3 and 6, but their near vision is worse than 6-9, or they had significantly reduced stereopsis, or individually if their lag of accommodation was high, these are patients where it would affect their literacy and phonological print awareness. So it's important to correct for these uncorrected refractive errors. So then we all give these prescription and we give these glasses. Do we really know it is helping them in school and what is happening? We don't know. So this is a study that was done by Johns Hopkins, Baltimore, in the area of Baltimore, and they found these patients and they had these patients followed from like when they were 3 to 7 years, seventh graders, I think, and then they were, because seventh, sorry, it says years here, it should be grade, and they looked at around 2,304 students, and the mean age was very 9.4 years. What they did was they did a study where, sorry, I went backwards. I think, am I doing the wrong way? Sorry about it. 1 second. I'm thinking, what am I doing? Okay. So these were patients were divided into 3 cohorts. Okay, so the districts were divided into 3 cohorts, cohort 1, 2, and 3. They were randomized. So the cohort 1 got the eye exam the first year, and they got classes, and they were followed into the second year. Cohort 2 got the eye exam in the second year, and so on. But it's important. Basically, they were able to do cumulative studies to see 1 year impact of giving the glasses. So they, in the United States, we have like this eye ready test and PARC test that are done at school for standardized reading assessment and math assessment, and they were able to do and follow these kids once they got the glasses. Did it improve their functionality in these tests? And they found that glasses improves their academic and math performance after giving the glasses for year 1. But year 2, it didn't sustain the improvement. But the year 1, immediately what improvement you got was sustained. And especially the children who were females, girls, and if they already were performing poorly and were in lower standard of performance at school, their performance improved significantly. So this is again evidence-based in a large cohort to show that when you give glasses, you are helping them improve their academic performance. So then a final part of this part is to think about, okay, if you give all these glasses, are we improving the well-being of the children? So are we able to, this was a nice big systematic review that was done to look at whether when you give glasses, is it helping their cognitive and educational well-being? And they looked at particularly mathematics, English, literacy, reading fluency, school function and grades. Are we improving their psychological and mental health? And overall, are we improving their quality of life? So they found about good studies, and they found about 20 studies. And in many of these studies, then they collated all the data, and in the 1999 to 2021. So it's not going far back. It's a relatively newer publication that were compared, and they had about very good evidence for educational well-being when they were corrected with glasses. Quality of life was improving, as well as decreased anxiety and better improvement in their mental health scores when these children were adequately corrected for their refractive error. So you are doing good in these cases when you're prescribing glasses. There is a lot of overall benefit that comes with it as well. So now let's go into a little bit about like amblyopia, strabismus, because there's a lot of literature now about amblyopia and strabismus, and how amblyopic refractive error can influence. Not only we are thinking about amblyopia itself as a holistic eye problem or a holistic brain problem, in a way that the deficits are not only at the level of the eye, but how the brain is processing the information. This is where newer technologies are coming in terms of dioptic treatments for amblyopia that is more challenging in terms of like improving more than patching rather than improving compliance, but also treating binocularly to improve function, so that how the brain and the cortical responses are improving when you're treating these patients are important. So there's a lot of literature from a big group of that, like Eileen Birch's lab, Fatima Ghazia's lab, and Anne Weber from Australia and their team. A lot of them have done many studies over the years prospectively to look at patients who are amblyopes, how they're reading and how they're scanning. So they found that amblyopes can have slower reading even when they're corrected, and if they still have residual amblyopia, they can have these deficits. They have a lot more harder time with multiple choice questions. They have increased fixation duration. They make more forward saccades, so they're making more and more saccades to kind of get through the lines. They have some fixation instability. They make poor searches and so on. So a lot of research showing that amblyopia can affect overall downstream a lot of the functional aspects of how they are reading. So it's important to pay attention to this, and we are also thinking more in terms of research lines, not only thinking about resolving their vision to 6/6 or 20/20, but how is their contrast sensitivity improving, or all the other mechanics, because there are other studies that go on to show how motion perception is affected, how lots of other factors are affected, and reading is one such thing. And these are like summative studies, like a recent paper by Birch and Kelly in Progressive Retina Report, I think is a good one for all of us to look into, where it summarizes how amblyopia is a whole brain problem rather than just an eye problem. And they have gone on to show how even for mild, moderate, severe amblyopes, they have significantly affecting their reading rate compared to controls. Even when they are fixating with their fellow eye, sometimes there can be deficits. Their forward saccades are a lot more compared to controls, and the reading rate correlates with the forward saccades that they are making as well. And this is a graph just to show across x-axis is the grade level and y-axis is the reading rate, and the green line is the control subject. As you go into higher grade levels, your developmental maturity happens and you start reading faster, but the amblyopes seem to saturate and have a difficulty in catching up to the control subjects. But when they are treated and it resolves, they seem to kind of catch up to the control level data. So there's evidence to show that when you treat amblyopia and amblyopia resolves, then there is a better chance of improving their other reading metrics as well. So then let's talk a little bit about convergence insufficiency, a little bit about the binocular vision aspect of it. So as you all know, many of you would have heard the CITT study. So optometrists long looked at convergence insufficiency and looking at that as a way in many children who might be deemed having learning difficulty, but actually might only have these subtle vision problems or eye teaming problems that can be treated. Many times patients are diagnosed. There was a question that was brought up saying, oh, they have attention deficit like ADHD kids. A lot of ADHD kids have convergence insufficiency or receded NPC typically. So sometimes treating the eyes might help overall improve their attention as well. And some of these exercises and vision therapy that we do probably not only improving semantics of improving vergence, but at the same time, they're also holding their attention, visual attention, and improving. So many higher order cortical function probably is improving when you're doing vision exercises in these patients. So the CITT study was the first study to show that eye exercises in office vision therapy to be very, very helpful. And it was compared to a placebo group of treatment. Even the placebo group did have some improvement, showing that always children improve when you give like children or adolescents. In medicine, about 30% of improvement that we find are all placebo effect because you are just getting a better psychological impact from all these things. But the actual treatment further improved their efficiency of eye teaming skills. The clinical findings improved. But people ask, oh, yeah, okay, fine, eye exercises improves their ability, but is it actually improving their reading and attention score? So they went on to do the CITT ART study, and they took patients who classically defined by convergence insufficiency, right? Not only receded near point of convergence, they had to have the exophoria at near greater than distance, they should have poor convergence ranges, and then they randomized them into 2:1 group for getting eye exercises or placebo therapy. And they found that compared to baseline, of course, the vergence and the vergence metrics and clinical findings improved, but their reading metrics particularly didn't improve. So it didn't, but the problem with the study was that they didn't take patients who had poor reading scores to begin with. So it's not that convergence insufficiency always causes reading problems to the level of learning disability. It can cause discomfort, disinterest. So these are patients who can read, who have no trouble like phonologically decoding words, but they just get eye strain and eye discomfort and all of those, screen time these days, and the more you're using up close work, you can happen. So you are helping them improve those symptomatology with your treatment. So you need to make sure you're adequately parsing it out when you're talking to these patients. So this particular study was unfortunately not powered to take patients who had poor reading scores. Rather, they already had pretty normal reading scores. You're not going to get too much delta that you're going to find from a study. But in these patients, it did improve function, and then their overall symptomatology overall also kind of improved with the treatment. So then a little bit about vision and learning difficulty. This is where we have a little bit of less of evidence-based. We've been trying very hard to study studies that are properly controlled, less biases involved in your interpretation and so on. So this was my prime work when I first started working at Boston Children's Hospital. We had a lot of, in a medical setup to do eye exercises, vision therapy is unheard of in the US typically. There's a lot of disregard between what we see eye to eye between ophthalmology and optometry. But so we had to do some foundational studies to kind of understand what we see. So I collaborated with the neuropsychologist at Children's who are running a learning disability clinic. So we took patients who are having dyslexia from that group. So what is dyslexia? Dyslexia is where it is a childhood problem for reading, where they have trouble with single word decoding, word recognition, spelling, and downstream, it affects your reading rate and comprehension and written expression as well. English is a complex language. There are some language where there is one-on-one phonology, but dyslexia is being recorded across all of the languages. Some languages are easy, even pictographical languages like, Chinese languages, you can have learning difficulty because it's got to do with how you're interpreting all these symbols and words put together, just different mechanisms maybe. But it is important to remember that it is a core linguistic problem. It's not primarily coming just from the eyes. It can be in certain cases where it's not typically dyslexia, where you can treat them with eye exercises because it's purely an eye problem. But in many cases, it's coming together because it's a combination of problem. So we wanted to take patients who have dyslexia and compare it to a typical reading group to see, do these kids actually have poor control of their vergence, tracking, and attention? So that way we can say, oh, okay, when you're doing eye exercises to them, you're also improving some aspect of their learning or how they're using their eyes that comes along with the remediation that they get at school. So we did a study, we got it published in JAMA, and then this is the study where we looked at these group, and we had like a prospective study. We had 7 to 11-year-old children from the dyslexia clinic and from the control subjects from the typically grouping leaders. We did their, we did their reading assessment, we did their intelligence test, IQ testing, and we compared between the groups, and then we did these testing on them. We looked at their visual efficiency, we looked at their visual attention, and a little bit on motion perception. The last two, I'll just develop on it a little bit, but the main thing we're going to talk about is the visual efficiency, which is the lower level processing. So to give a synopsis, in our study, we did find that the dyslexic group had a larger amount of percentage of deficits in their vergence and accommodative deficits compared to the typically developing readers who did have something going on, but they typically you just pulled them up from the clinic. They were not symptomatic. They were not getting any vision therapy or anything. They were just normally doing well in school kind of children. And we did find that there was higher incidence of these deficits in the dyslexics group. Then we went and looked at the tracking. We did the DEM as well as we did their visual tracking using the visograph. And we found that the horizontal time and the errors that they made, the dyslexics did make a larger number of deficits compared to the typically group readers. And we put them on the visograph. And even on the visograph, we had them use their word ID. We figured out which dyslexics were almost reading to grade level and which ones were reading below grade level. So we can control for what text they were using and they were actually scanning with their eyes. And we did find that the dyslexic group were having poor reading rate. They made more fixations and they made more regressions when they were reading because they were going back and forth to kind of get the semantics of the information in. So putting together, which is why I'm doing these graphs, is also for you to remember that the vergence, accommodative system, and the visual system for tracking are all kind of interrelated, and one feeds into the other. That's why in many cases, when you have a convergence insufficiency, you might also have an accommodative problem. This is where it's important to understand the semantics of how the eye is working and how accommodative system is working. And I didn't go into those details because that's your semantic lectures that you'll be getting. But we think about accommodation as proximal accommodation, because something is near, we know we can accommodate. When we talk about fusional ranges, we talk about fusional convergence as well as accommodative convergence, proximal convergence, tonic convergence. There's so many aspects of it that make sense to think about because it knows what you're training, and when you're treating all these voluntary convergence and other aspects of it to help compensate for some of the deficit. So this is what we found in our study. So then I'm going to go a little bit into attention. This is just for you all to know some little bit of semantics of it. When we think about the eye, we only think about vision as what is processing from the occipital cortex. But brain, the visual system is fascinating, right? Because information is getting processed all parts of the brain. Almost 50% of the brain is involved in some aspects of visual information processing. You have the parietal cortex, which is what we call as the dorsal pathway and the ventral pathway. Ventral pathway is what is acuity, your color, your like static things that you're seeing. Your parietal pathway is so vulnerable in many cases, especially in dyslexic. This is where it is the magnocellular pathway where things are motion, your eye movement control, how you're using your eyes, how you're fixating with your eyes, and all this is affected by your parietal system. So lots of literature from psychology or experimental psychologists or vision scientists have shed light about this pathway being more vulnerable and why dyslexic might have these deficits. And when you're training them, you're training kind of this pathway to kind of hone into all this process. And all this is controlled by something called visual attention, which is mediated by the frontal cortex, which kind of top down goes down and says, okay, I'm going to alert these attention and this is how I'm going to be reading. It brings order into the system. And so you are able to perform well. So this is putting in a nutshell something about how higher order visual system can affect information. There was an interesting group of researchers in Italy where they did a study where they took children who were, before reading got introduced to them, they looked at them to look at all their pre-reading score and they looked at their visual attention and they could figure out who had poor attention and good attention, visual attention, and they could predict who could become poor readers in the future as they followed them prospectively. Then they went on to do a study on those poor readers. They made them play these action-based video games, which are non-violent. It's a Wii game called Raymond Raving Rabbits. It's probably not there anymore because people are not playing Wii anymore. But it was an action-based video game just to say if there were multitasks that are happening on the screen and the child had to alert attention to so many of these aspects to do the task, they would come in every week into the office to do it. And they found after 12 weeks that their actual linguistic score improved. So like word reading score improved. So something non-linguistic task was improving linguistic performance. So something to do with eye motion control. This is where I was talking about initially, that why dyslexia is a language problem, but sometimes these eye movements or eye training thing can help improve visual attention and stability and oculomotor stability. So you might actually be improving their ability to keep track of the lines, scan lines better, not lose fixation, and those kind of things that can come along with the reading remediation that they are getting. So one of the quick studies that we also did is visual span, because many of these kids have shorter spans. That's why they have to make so much more fixation. So we did a presentation span where we had 5-letter sequence of random letters that don't have a vowel in them. So you can't make out or imagine a word that comes out of it. And then we looked at their very, very shabby video of it, but the fixation target and the letters would come and they have to say TLRPS, DFHPB. So they have to remember and they have to say it and somebody's documenting it. So we had 20 presentations like that and we tried to figure out how well they did. So we found that the dyslexics counted in these red symbols here, they are the ones who are making more. By the time they come into the third and the fourth thing, crowding happens and they're having more issues. Even control subjects do that, but the dyslexics start having more deficit from the third position itself. And so typically 1 and 2 are okay and the last one somehow they remember, but the middle ones are the ones that are harder to find. So the dyslexics had a harder issues with the letter position and the number of sequence of letters they found. Because we did 7 to 11, we divided them into 2 groups just to see how they were doing. And we found that the dyslexics, as they get older, they come closer to the younger typically group readers and then they get stuck in that area. That's why they still have fluency issues. They might do okay with comprehension, but fluency is very hard to kind of retrieve and train. So that is where I think vision therapy, eye exercises might play a role to help improve processing speed and thereby influencing improvement in their ability to process and scan faster and read faster. So that is, and then we found this is a little bit, I'm going to leave some time for questions, so I'll just rush through this. We did find that the visual span particularly relates to how they were doing on their reading metric scores as well. Sorry, same thing, a couple of slides being repeated here. So overall, this study, we showed that, yes, this is a comparative study. It is not cause and effect study. It is important to understand that the study supports that vergence and accommodation and visual tracking are helpful assessment to do in these children and help them, but they're not causing the problem. And it's important to have a good comprehensive eye exam. And it's also simultaneously, they should have all the evaluations at school. It's possible when you treat them, there is improvement, but we have no studies so far that that is conclusively giving us enough evidence to say if you treat them, you're actually improving their reading metrics as well. But there are subtle evidences here and there. And intuitively, as an optometrist, as you start seeing these signs and you start seeing these patients, you kind of see some trends where there is some benefit that's happening. But at the same time, the child is also growing, also maturing, getting so much other reading influences too. So sometimes it's so difficult to parse out what is causing the difference in getting the improvement in the patients. Last bit, I'll talk a little bit on concussion. Concussion is something that we are all getting more and more familiar with because many patients are probably concussion previously probably ignored, but now we are getting more attention to it because post-concussion, we are noticing a lot of eye problems. So these are patients that I saw in my clinic from 2012 to 19, about 300 patients who came into my clinic, and a good patient came because they had headache complaints. A lot of them have reading difficulties. They were good readers before, and suddenly they have struggles with reading, and they complain of blurry vision, difficulty focusing and concentrating. We did a recent prospective study, we just published this, where we found that compared to control group, the concussed group had a lot of deficits in vergence and accommodation and a good overlap between the deficits as well in the concussed group. And we are showing this more compared to even naturally occurring problems in these post-concussion. There is a lot of these deficits. So these are cases where maybe when you give them reading glasses for their accommodation or treat their convergence issues, then you could actually make a big impact in their symptom recovery. And this was a study that was done by a state here in Alabama. They had a REDCap database, and they looked at, okay, if they followed these children within 21 days of having the concussion, how were they doing? And a lot of them reported academic difficulties, as well as a good portion of them reported vision difficulties, and they were correlated. If they had vision symptoms, it was more associated with having academic difficulties. So I just wanted to showcase you how important it is to do a proper eye exam and give some evidence-based structure to why uncorrected hyperopia, uncorrected astigmatism is important to teach, and also prescribe proper glasses for them, and how important it is to identify binocular vision problems. Though we didn't go into details, convergence insufficiency is one, accommodation is a lot, tracking problems do come about. And I wanted to show you some evidence about how dyslexics can have these problems, but it might not be causing their dyslexia, but could be a coexisting problem. And in concussed as well, you need to think about vergence and accommodative system being affected. So in summary, I would say it's important to identify uncorrected refractive error so that you know exactly what age when you're identifying them. It's important to understand developmental stages and when to incorporate these corrections that you want to give. It's important to do a comprehensive visual function assessment. Make sure you are having a structure, and you always do, like I always do all the tests that I talked to you about. Vergence, I do the 3 metrics. Accommodation, I do the 3 metrics. Tracking, I do the DEM, and I do some free space. So I kind of put together, so that way when I'm following these patients too, I know exactly what I'm looking for and whether there is improvement in the scale. And educate the families, make them understand how these can influence, especially when you're screening them. Families these days, preschool screening is getting important. Schools are screening at 4th grade, like first grade, second grade at schools. And when you get targeted and you find these patients, you need to make families aware why it is important and why there are studies to show that it can affect how they're performing at school. And so it's important to pay key attention to how they are growing and how their developmental hyperopia is changing over time. And important to talk to them about strategies. Accommodations at school can help go a long way. Don't just say, please increase font size. Font size increase doesn't do anything to these patients. It actually makes them read much slower. So make it optimized, the spacing between the lines, less crowding, using negative contrast like this, like a chalkboard appearance with black background and white lettering, or all some of the easy accommodations that we can give for school that can reduce eye strain and eye discomfort that they could be having with close work and reading. That's what I have. Sorry, that's an incessant talking for like.
Shamla, have you lost Aparna ma'am, or is it just my computer?
Yes, ma'am. Ma'am.
I think we have lost her signal.
I think we've lost her signal, right?
Yeah, ma'am. Yeah.
Can you hear me, Sharanya?
Sorry, I was muted. Yes, I can
Good,
hear
good.
you.
Sorry,
I
I'm
can
connecting
hear
on
you.
my phone. I'm so sorry. I think something is slapped
Oh,
on
no,
my
no, no, no,
computer.
no, no.
But
Perfect.
but yes, I think there was some question about the flipper on the
Yeah.
chat, right?
Yeah, I'm just
Yes.
trying to figure out. Yeah. So Flipper is available. I think they were talking about Virgin's Flippers at that
Virgin
point.
slippers. Okay.
So they want to know whether it can be used. What can we check with? I don't know what they mean by which meridian we have. Oh, okay. I think those are two questions.
Yes, yes. I know what the second question is about. So the second question, the neutralizing meridian, I think they're talking about dynamic retinoscopy and MEM when you're doing it. Be consistent, okay? So for example, if it is a corrected person, right? They're ideally corrected, then it should be the same both meridian. You do it plus 180 or 90, it shouldn't change. But if it is an uncorrected hyperope or an uncorrected astigmat, you will notice one will be with or neutral and the other one will be like a lot more change. So you can pick up on those things, but be consistent. If it's uncorrected, just check the same meridian. For example, in your distance retinoscopy, you've gotten +2 diopters with a -1 at 180, then I would come up close and I would check around like the 180 meridian and keep it consistent so I can subtract it properly. So that way you know how they are. So make sure the meridians you cross track it, transpose it, but in your mind you should make sure that you're looking at the meridian that is more hyperopic. So typically the more width meridian is what you want to neutralize for your accommodative response. But in most cases you want to make sure that the patient is adequately corrected. Yeah. And then
somebody's asking for a recording of the session. It will be loaded on the Inspire page, so you will be able to look at it sometime. I mean, of course, Shamla, have you got permission from ma'am for that? Aparna,
Yeah,
to load. Is it okay if we have it?
Yes, I think it should be fine.
Yeah. So there's one interesting question. How do we adapt convergence and accommodation tests for non-verbal and developmentally delayed children?
Yeah, no, very good question. This is where it is important for you to have your objective measures. My clinic, almost 1/3 of my patients are developmental delay, and so you got to be. So what are your cues? You can use your NPC. You can subjectively observe for it, and sometimes they might not fixate. Come up with an interesting target. You will see with a sticker. You can figure out like sometimes they like lights. Different sources. So you have to just come up with different techniques. This is where your NPC, your retinoscope, your accommodative dynamic retinoscopy will all come into play. I am also able to do fusional ranges or the Virgin's facility. I'll just take it and just look for the response because innately their brain will correctly correct for the convergence, because they're seeing double and they will be able to make it single. So use your objective measures. These are the cases you're not going to get any subjective response from the child, right? So you have to think fast, think at your feet, and be able to. There's no new rocket science test. You have to use the test that you have and use it to your advantage. If you know exactly what you're doing, what instructions you're giving, it's going to be second nature with time. You're muted, Sharanya.
I know. Shamla, do you want to just ask Aparna ma'am the rest of the questions that were already there?
I already shared Aparna ma'am. I think she had added in the presentation already.
No, I kind of quickly, I think one of the questions was like impact on learning, like how questions on how binocular vision affects for school age children, which we talked about how we don't think it directly affects comprehension, but it affects more of like their ability, their eye strain and how they're using it. In some cases, it can affect comprehension if they have coexisting dyslexia and learning difficulty, but you need to make sure you are not making the call that if they have a true learning difficulty, it is coming just from the eyes. That's one of the perspectives that many behavioral optometrists take, but you got to stay neutral. You got to keep it open-minded, and because you don't know what is happening on the learning end, but you can always try your best to do their visual system to make it the best. Then one of the questions you asked was respondents ask about potential misdiagnosis of binocular vision dysfunction as attention deficit or reading disorder, which is what I tried to make in my presentation. That many times also there's a research about 1/3 of patients with convergence insufficiency have ADHD. So many times there are parents anecdotally who come out and said, oh, my kid has I don't want to put them on any medication, but let's try some eye therapy. But you don't know, there are so many facets to this, right? So you do not know completely if the developmental itself was improving, what other mechanics were improving. But eye exercises do improve your visual, your one-on-one, making the eye focus and sustain. So it's probably not at the level of the eye, but at the level of the brain, and how the eye and brain are coordinating that you're improving. That makes a big difference in these patients. There was someone on the chat. Sorry, let me see. I'm so sorry. So I never have these technology
It basically
things,
says, yeah, don't worry about it. I'm also not so great with Teams. So anyway, how do we interpret borderline values and when do we decide to intervene?
Very good. I think this is where I also struggle all the time in clinic, right? Because I'm starting to more and more, things are not cut and right? It is important to know what is abnormal and normal values, but it is also important to know what is relevant for a child when they are complaining. When children are high performers already, they're already driven and given a lot. These are patients that you'll see after concussion, or even like an A student, who comes and complains that they're having difficulty. So in these cases, look for symptom provocation. Like when they're doing the testing, check if they're feeling more eye strain. Like they will do all sorts of, like, concussed especially will have a lot of symptom provocation. Physically, you will see that they're getting distraught from doing the test. So gauge normal, abnormal based on what the patient is presenting out from. So you can always improve. So you can eye pitch like this. I say, looks like your clinical findings are normal, but I can clearly see you complaining and you're having these issues. Maybe there are many factors. Maybe you are more stressed at school. Maybe these are the 10th and 11th graders. There's so much pressure at schools, pressure from parents, pressure from computer, media, how much they are doing. So there's so much that comes into play. I myself had convergence insufficiency when I was doing my optometry program, but it went away. Why did it go away? Because I was probably, there's so much going on, so much stress, and it just downstream comes and affects your system, right? Like, so sometimes you just need to do the proper. So borderline measures are okay. So you don't take it as you have to become an astute clinician where you observe findings, know what is normal, abnormal values, but be able to gauge that for the patient that you're seeing. Always think about the individual patient on the chair. And sometimes you can put it this way. You can, if you're giving eye exercises to them, you can say, you know what, your numbers look normal, but you're complaining. Let's do this. These eye exercises are going to give you a headache in the beginning. It's going to give your symptoms more. But once you prod it and push it, it's like doing your strength training, I bring that all the time. I say, if you're doing tricep, bicep training, you're putting weights and you're doing only 5 pounds the first time, and then you do 10 pounds. It is unbelievably uncomfortable. But don't you push through because you want to get stronger? That's what you're doing to the eyes. It is the same muscle, same oxygenation that needs to go to those eye muscle fibers. So you're only making it stronger. So no harm. You're only going to make it efficient. So it's how you put it. Frame it positively. Frame it like it is not causing all their underlying learning problems, but you're just alleviating some of the symptoms and seeing where it goes.
Yeah, absolutely. I mean, I think the key thing is to be able to identify what each patient needs and then work based on their needs rather than just going by a set of, normal
Rules,
and abnormal numbers. Yeah.
And that will never always not work in many
Doesn't
cases,
work.
but it gauges you. It helps you when you're talking to a provider who's very suspicious about what you're doing, that you did this in a consistent way and you're maintaining. That's all they are looking for, that you are doing your due diligence in doing exactly what you need to do in your measurements. It's like a key.
There's a very interesting question. What's the right time of the day to give functional exercises?
Oh my God, such a, so I give it in both manners. So I tell the families when I don't do in-office vision therapy, I send home with exercises. Not the best part, but that's how I can do in the medical setup I am. So I always tell the families, in the beginning, because you're trying to learn, I don't want to frustrate the child more. Do it when you're fresh, maybe start on the weekends. In the weekend when they're having the breakfast, after that, try to do some 10 minutes of this exercises to just to get the hang for it. And then, but as they start doing, like I give a lot of computer-based programs to do. So when I do them, I tell them initially do it when they are more getting familiar with it. But then at times do it when you're a little bit, I also say when you're really tired at the end of the day, just to see what your system is doing. So you know where your vulnerabilities are. So I titrate it. Initially, I tell them, not that families always follow. They all are going to do what is flexible to them. You can't, if you're doing in-office therapy, you can't mandate when they're going to come into you. Sometimes you're going to see them at the end of the clinic day or sometimes in the morning. So, but this is something you can gauge. You can tell the families to do in the beginning when they're a little fresh and not so tired, mostly in the mornings. But as the therapy, are they doing more? Try to do it at different times so that they can push their system to their worst scenario and do the exercises to build more endurance.
Yep. So there's another question. I think you kind of covered this in your talk about convergence and accommodation tests to be done and interpreted for preschool age group.
Yes.
And
So
what is
preschool age,
with normal development?
yeah, preschool age group is, it's, a lot of, I think one of the questions tied into it also, how are we able to do early screening? So in terms of preschoolers, I think you just stick with what you already have. Your retinoscopy is your key. You're identifying just basic vision, your depth perception, your cover test, and your, that's all that matters that much. Your cover test will tell them if they have like intermittent, etc. Maybe you can do a quick NPC, but your NPC, this is so underrated. Your NPC can also be affected in amblyopes, right? Because amblyopes have poor vision in one eye. You bring the target, that eye will go out because it can't sustain that effort to see the target. So in these cases, it's not a convergence problem. It's because accommodation and how anisometropia is working that's making the problem, right? So then in these cases, give glasses. Like you have to just make sure that they are getting corrected properly and getting to the right place and getting the glasses done. So preschool level, I wouldn't say put so much stress on your binocular vision exam. Trust your retinoscope, trust your cover test, I think those are key. And if you're able to get them to do some stereopsis test, that three puts together to give you a story. That's all you will need. And if that doesn't, and then as they go into first grade, like kindergarten to first grade, because these days children are put to reading much sooner than we are. We started like reading later now. These people are reading chapter books, like Harry Potter books, like probably in first grade, you can see them with these chapter books in their hand. So I think the demands for their system are a lot more. That's why many of these kids complain of like eye strain. They don't have reading problem. They'll come to you saying, oh, my child is a great reader, like can even read Harry Potter book, but I don't know what it is, but something is happening and they're just skimming through. They're not cognitively putting that effort. So contextualized, but preschool, I'm not too concerned. You have to just do an adequate refraction.
So there's one last question. I think we're going to finish with that.
Okay.
What home therapy software do you use?
I actually use something called as the HTS, which you all might know. It's the home
Right.
therapy system. That's the one that has been, because Jeffrey Cooper designed it. He's a big clinician from New York. He has like if you're all into OEP and the behavioral optometry group, he's a therapist, but he's a good scientist. He's a good vision, like principally, these are old school optometrists who thought a lot about how the visual system interacts. So it's his group that divided, and it was the most accessible. I still use it, and it has like variations, and they also have a in-office one. It's expensive. I myself don't have it, but I use the HTS. More than the HTS, I actually use the CVS a lot, even though it's only Virgin's training, because children have such poor bandwidth to do these exercises at home for more than 15 minutes. So I give them flippers for handheld accommodative later. So I grade them and see, if I give them only a few things at the beginning, I'll give a Brock string and a CVS program in the beginning, have them come back into the office. If they come back to the office, then I'll give them a hard chart, then I'll give them the flippers, then I'll add loose prisms. So I'll try to do more free space to get a lot more range, and then I'll do the computer. But I use the HTS program. Recently, I think at the Academy Conference in Boston only, I got to know about this program called iHero, which seems to also look good. So I'm looking into it right now to see what kind of techniques are there. But I know you guys have a lot more too in India, with a lot more independent people designing a lot of fun things. Like even your presentations have such great emojis. So I think there's a lot of computer people like who can do a lot more. But the HTS is done, and it's a couple of research studies were also done with the system, and it's very easy and it's compatible. I've given to some families who've gone to India with the program installed in their software and be able to do when they are visiting home for. It just needs a proper internet connection, I think. But that's a good one to use.
All right. So Shamla, thank you so much, Aparna.
Thank you. I hope the in between was okay. Sharnya, I didn't end
Absolutely no
properly.
problem. We just missed you. We just missed you for a few seconds. That's okay. Don't worry.
Perfect.
Thank you for your insightful presentation, ma'am. Oh, I hope everyone who joined today's series would have gained more knowledge regarding the topic. Before we close, I just posted the request link in the chat box. Certificate with 2 credit points. Do fill it and get the certificate. Thank you.
So Aparna, I think your talk generally today, for those who have been practicing, it's just reiteration and saying, okay, we're all going the right way. For those who are starting to practice, I think they're learning that these are the things which are important.
Yes.
But I really love the fact that you emphasized on the use of the retinoscope. It's something which is kind of a dying art in a lot of places, and it is something which I'm like desperately promoting over here. So really, really happy that you mentioned about the retinoscopy as well. Thank you so much. Absolute pleasure. I think Gopi wants to say something.
No, thank you so much.
Yeah, thank you so much, Dr. Aparna and the team Acchutha for putting up this. I really loved it because, as Saranya ma'am mentioned, you emphasize the role of using retinoscope. As I teach visual optics over here, and I also emphasize the role of this, retinoscopy. And I hope the session has brightened so many young minds. So before we close, I take the responsibility of closing this because I am close to Inspire series. Yeah, so the audience can actually watch the entire session once we upload it in our YouTube channel, which is called Acchutha Institute of Optometry. They can search in YouTube and subscribe to the channel. Once we upload it, maybe as and when we find time, we'll circulate the links to everyone as well as to you as well, so that you can share it to your peers and they can listen to it as well. Yeah, over to you, Saranya ma'am. Thank you so much.
Thank you. So it's a free subscription. There are no charges. Please feel free to use it. There are a lot of interesting talks which have been loaded on by a lot of really good speakers, experts in their own fields. Make use of it. And if you have any particular topic that you would like us to cover or would like to have some speaker, please let us know. You can reach us on either the Institute webpage or you can reach us through our YouTube channel as well. And we'll be happy to try and reach out and try and get them to come and talk to us. Thank you once again so much, Aparna. You've spent so much time doing this. Absolutely wonderful listening to you. And
No, my pleasure. Thank you so